Good afternoon, good evening, everyone. I'm Khalid Al Habib, Professor of Cardiology, King Saud University in Riyadh, Saudi Arabia. And my great pleasure and honor to moderate this and chair this session with the top scientist and editor-in-chief of the European Heart Journal, Professor Filippo Curia. This is the Virtual Research Academy under the Saudi Heart Association. And the goal and the main vision for this forum is try to establish a culture of research in the Middle East and hopefully around the world by meeting top experts and world-renowned scientists in the field of medical research. So today it's a nice interview. It will be no slides involved, so it will be just a friendly chat with Professor Kriya. With the title of the Coronaries, European Heart Journal, and what it takes to publish in high-impact journals. Professor, excuse me, Kriya, he's editor-in-chief of the European Heart Journal, director of the cardiology unit at a hospital in Italy, University Department of Cardiovascular and Immunological Sciences, Catholic University of the Sacred Heart in Rome, Italy. So, Professor Kia, nice to have you with us in this forum.
Thank you, Khalid, for your nice invitation.
It's a great pleasure, and our pleasure is ours. It's a great honor and pleasure to have a scientist like yourself, a top scientist, a world-renowned scientist in his field, to really meet with us in this afternoon to tell us about his journey, his new position as editor-in-chief of the European Heart Journal. I had the honor of being a part of your co-editorial board, being an ambassador to the European Heart Journal the last couple of years. So it has been and still is a great experience for myself, a great learning experience, and be happy, very honored and pleasure to serve this top-notch journal. And then we'll end with your wisdom, pearls of wisdom to the to young scientists. So without further ado, would like to talk first about your beginnings. How did it all start? When did you start your journey in medicine? And then we'll follow that by what you consider major milestones in your career. The floor is yours.
Well, Khalid, thank you again for your prestigious invitation. It's a great honor to be here with you. And thank you also for this opportunity of sharing my life with you. All started in Pisa. I graduated in Pisa, very important university in Italy. And then from Pisa, I graduated in medicine. And then my first passion was the heart. When I started medicine, I was uncertain between medicine and physics. And I think that this influenced my choice for the heart, because, so to speak, the heart is a highly mathematical organ. A lot of physiology and pathophysiology of the heart can be explained using equations. Think very simply of fractional flow reserve. So I always perceived the heart as a highly mathematical organ. And this is why I started in cardiology. And then immediately after my graduation, I had the opportunity to move to London, where I spent 15 years. I went to the Hammersmith Hospital, which at that time really was a top hospital in Europe. And it was when I was at Hammersmith that I got interested in particular in ischemic heart disease. Well, first because of the large epidemiological impact. Is a very frequent disease. And if you go to statistics, well, this remains, in spite of extraordinary progress, remains the #1 killer in Europe, and not only in Europe. 20% of people die, of men die of ischemic heart disease. And also 20% of women die of ischemic heart disease. Among women, mortality for ischemic heart disease is 10 times higher than mortality for breast cancer. So women need to pay attention to breast cancer, of course, is an important cause of disability and death, but mortality for ischemic heart disease is 10 times higher. So I was attracted because of this massive epidemiological impact, but also because early in my career as cardiologist, well, in the textbook, I studied that the dogma was ischemia can only be caused by stenosis. We cannot have ischemia without stenosis. That was the dogma when I graduated. And then 4 or 5 years after my graduation, I met a lady which had chest pain. Well, the same chest pain I could read, anginal pain I could read in textbooks. The pain was really described by the book very precisely. I could recognize that was the anginal pain I could read in textbooks. And stress test was positive. So I thought, well, let's go for coronary angiography because the pain was really invalidating. And then I went for coronary angiography, and coronary arteries were patent, angiographically normal. And then I asked myself, well, this is against current wisdom. What can be the cause of angina in a patient who doesn't have coronary stenosis? And then I went through the literature, and my observation was not isolated. There were already articles presenting these patients with this unusual feature of angina in the absence of stenosis. And actually, that syndrome had been labeled syndrome X. And X stays for, well, we don't know what's happening here. This triggered my curiosity. And then in the following decades, it's been a long journey. I managed with other colleagues to drop the X.
So how did you drop it?
Well, I dropped we dropped, and I've been one of the protagonists, but with other colleagues like Juan Carlos Caschi in England and others. So it's been, as usual in science, teamwork. I gave my contribution. And well, the first thing I asked myself was, okay, but do we have the proof that this is a cardiac disease? And the first evidence that this is a cardiac disease went from a study where we use MIBG, which is a tracer to trace catecholamines. And if you inject MIBG in a normal person, you find the silhouette of the heart. There's uptake in the heart. When we used MIBG in patients with syndrome X, at that time was called syndrome X, there was in 70% of these patients no uptake. So that was the first evidence. Okay, this is really a cardiac problem. It's not, these are not funny ladies who describe a pain which can have perhaps a psychological origin or expression of anxiety is frequently was frequently said about the syndrome of angina with normal arteries. And then the next question was, well, okay, but what is the evidence that these patients really have microvascular dysfunction? And then CMR helped a lot in this direction. And using CMR, we managed to find evidence of regional hypoperfusion in these patients. And then the next question was, okay, so it's a cardiac problem. There is evidence at CMR that there's microvascular dysfunction, but where is the evidence of ischemia? And you know, this was an important question. To find microvascular dysfunction doesn't justify per se the presence of ischemia. In particular, because in this lady, during angina and the state depression, when angina and ischemia are induced by a stress like dipyridamole or adenosine, these patients do not develop regional wall motion abnormalities. You know that if there is an epicardial stenosis and you challenge the patient with dipyridamole, the patient develops angina, ST depression, but also wall motion abnormalities. While these patients experience chest pain, develop ST depression, but no wall motion abnormalities. So the question was, okay, so this microvascular dysfunction can cause ischemia. And even more challenging was the fact that, you know, the earliest marker of ischemia is lactate production. And if you sample the coronary sinus in these patients, typically you don't find the lactates. So the question was, okay, but how can we have ischemia without production of lactates and in the absence of regional wall motion abnormalities? And then we thought, okay, well, perhaps we need a more sensible marker of ischemia. And we know that ischemia is followed by reperfusion. And if it is true ischemia, then there is a reperfusion damage, which can be identified by measuring free radicals. But free radicals are very volatile. So you can measure stable product of free radical production, which are lipid peroxides. And this is what we did in a critical study. We sampled in these patients from the aorta and the coronary sinus. And during stress, pacing, atrial pacing induced stress, we managed to have production, to show production of lipid peroxides, which was similar to that produced during PCI at the time of balloon occlusion. So this was the final evidence that indeed was not syndrome X, but what we call now microvascular angina. Well, I've summarized very briefly, but as you can imagine, it's been a long story. It is always difficult to challenge a dogma. And the dogma that ischemia can only be caused by obstructive atherosclerosis was a strong dogma, difficult to really challenge. But eventually we managed, and now microvascular angina is in guidelines.
Well, this has been always a feature of top scientists like yourself. They don't accept the norm and they challenge the status quo and what we accept as a given. And remember, Syndrome X was written in textbooks a long time ago, and that has been changed recently. And not only they don't accept like yourself, the usual wisdom, they challenge the what's happening, and they try to go further and further and investigate further. They don't stop. Any quick recommendations on how to manage such patients, because they end up in psychiatry, they end up in many other clinics? So any effective cardiac drugs, and does it help to refer to psychiatry or to be or not to refer to psychiatry? When do you consider really this is all in their heads, as opposed to this is true ischemia and needs to be treated?
Well, the interest in microvascular angina, but not only microvascular angina, because another chapter which is linked to microvascular angina is epicardial spasm. Epicardial spasm is another cause of ischemia. If we put together epicardial spasm and microvascular dysfunction, then we have this important chapter of, I call them functional coronary alterations, as opposed to structural coronary alterations, epicardial stenosis. Well, the important, you see, it is interesting because once we defined what is microvascular angina, proving that it is an ischemic syndrome, in addition to epicardial spasm, well, then some data which remained without an interpretation became clear. For instance, more than 10 years ago, Manish Patel published a very interesting study in the New England. Was a large population of patients with suspected angina who underwent coronary angiography. And in the subset of patients with typical chest pain and a positive stress test. Well, 50% only of these patients had obstructive epicardial stenosis. This means that the population of patients with suspected angina, typical angina, and the positive stress test, the prevalence of a functional alteration is up to 50%. It's a massive population, which for many years has been totally neglected. And when Manesh published this data, this interesting data, his conclusion was, okay, these are false positive. These are psychiatrical ladies who have, yes, angina and yes, positive stress test, but it's not an ischemic problem. So it's a huge population. And that was 10 years ago. But if you go more recently to the ischemia trial, I'm sure you and our colleagues know the ischemia trial very well. Well, I remind you, in this trial, patient underwent first a blind non-invasive coronary angiography, CCTA. And then after, the remaining patients were randomized to medical treatment versus intervention. But why CCTA before randomization? For the simple reason that in these trials, they want to exclude patients with mainstem disease, which definitely need to be treated, and also patients without stenosis. There's no reason to randomize patients without stenosis to intervention versus medical therapy. Well, these patients initially screened with typical chest pain. In order to be screened, had to have moderate to severe ischemia at a stress test. Well, in this original screened population for ischemia, almost 30%, 1 out of 3, was excluded because didn't have obstructive atherosclerosis. So again, it's a frequent syndrome. And you know very well, can be very invalidating. Now, recently, we have set up a task force. It's a global task force with colleagues from Europe, Asia, Australia, and States. And we wrote a certain number of papers on dysfunctional alterations. And in one of these papers, basically we say, listen, the ideal place where to understand if angina comes from the heart, if it is of ischemic origin, is the cath lab. In the cath lab, really, you can establish whether the pain is of ischemic origin or not. And we recommend 3 steps. Patient with suspected angina, you can initially try a test with anti-anginal treatment, but if they do not work, then you need more information. So the ideal place where to investigate these patients is the cath lab, with 3 steps. The first step is to assess the presence of obstructive atherosclerosis. And that is what we do every day in the cath lab. It is quite straightforward. You inject your contrast and you go for coronary angiography. If stenosis are there, we assume, and perhaps we are wrong, but we assume that ischemia is caused by stenosis. If in the patient with suspected angina, we don't find stenosis, the second step is to measure coronary flow reserve and microvascular resistance. Because if coronary flow reserve is less than 2, or microvascular resistance are higher than normal, well, this means that these patients have a stenosis, but the stenosis is not in epicardial vessels, but the cause of the reduced coronary flow reserve is impaired microvascular dilation, which is a cause of ischemia. It's like having a stenosis, which is not upstream, but is downstream. If this is normal, then the third step is to challenge these patients with acetylcholine, which is an extremely safe test because half-life of acetylcholine in blood is 2 seconds. So once you give it, even if you have a massive spasm, this resolves with help of nitrates in seconds. And this is the third step, which allows you to establish the presence of epicardial spasm or of microvascular spasm. If acetylcholine causes ischemia and the depression in the absence of epicardial spasm is microvascular spasm. Now, if at the end of the day, all these things are negative, no obstructions, normal CFR, normal response to acetylcholine, then you can confidently conclude that the pain is not of ischemic origin and you have to go for the psychiatry, which is a possibility, or you have to go for digestive problems or something else. But you can rule out an ischemic origin of pain only at the end of this sequence of tests. And this is my message for my friends in your who are listening to us.
Thank you. Now, what is the proportion of cath labs that do this methodologically, as you nicely explained, let's say in Europe? In your experience, do people go through this, or do they just empirically treat?
Well, the number is growing. It's a growing number in Europe more than in the States. And I hope that this number will increase also in Middle East. The challenge is there. These patients are out there. If we cannot miss them, first because pain can be very severe, and second because the outcome is not as good as we thought years ago. But also treatment is really optimized by a better knowledge of the mechanism of ischemia. This is a nice paper published by Colin Berry called Cormica, published in JACC 2 or 3 years ago, where it's a randomized trial, patients with angina and ischemia, but no obstructive atherosclerosis, were randomized to two arms. In one arm, treatment was guided by angio, basically nothing because coronary angiography was normal. In the other group, the treatment was guided by the functional assessment of coronary circulation. And the outcome was, in terms of symptoms control, was quality of life was much better in those patients in whom treatment was guided by a functional assessment of coronary circulation. And this is not surprising because, as doctors, this is a general rule, not applicable to cardiology only or to ischemic heart disease. This is a general rule. As doctors, we function much better. We are much more efficient if we can watch our enemy, which is the disease, in the face. If we know the details, hopefully the molecular details of our enemy, then our treatment can be more efficient. And of course, this is no exception. If we know the mechanism of ischemia, then treatment can be more efficient. If ischemia is caused by epicardial stenosis or by microvascular dysfunction characterized by reduced coronary flow reserve, then it is obvious that we have to use calcium drugs which reduce myocardial oxygen consumption, typically beta blockers, can be ivabradine, can be ranolazine, but drugs affecting oxygen consumption. While if the mechanism is epicardial or microvascular spasm, then you need vasodilators, typically calcium antagonist or nicorandil, where available. It's not available in Italy, for instance. I don't know in your country, but it's another interesting drug which can be used in this case. Then we have also some patients with microvascular angina who have what we call a sensitive heart, which means that the pain is really exaggerated, is more than expected based on the amount of ischemia. In these patients, we have shown, our group and also others have shown that in this patient, pain processing and brain pain processing is altered. They have a sensitive heart. The painful stimuli are more intense than justified by ischemia. In these patients, what can work are antagonists of adenosine. Typically xanthines like theophylline, which is used usually to treat asthma, but can also be utilized in these patients with intense pain perception. This is something I showed long ago. That was a paper I published in Circulation showing that the mediator of anginal pain is adenosine. The excess of adenosine released during ischemia stimulates pain receptors in the myocardium. And this signal, when this signal reaches the brain, then the patient experiences angina. Adenosine antagonist in the presence of a sensitive heart can be useful to reduce this painful stimulus. Other drugs, imipramine, which is a drug initially used for the treatment of depression. It doesn't work as an antidepressant drug, but is another drug which can reduce the painful stimuli reaching the cortex. So this is the three possibilities in terms of treatment. We can reduce myocardial oxygen demand if the mechanism is related to that. We can prevent spasm, or we can also work on by modulating pain perception. And to know the mechanism of ischemia is important because it happens to me frequently that the patient with a microvascular or epicardial spasm, if I put him or her on calcium antagonists, for instance, well, the usual doses of calcium antagonists may not be sufficient to counteract vasoconstrictor stimuli. But if I have evidence that the mechanism of ischemia is spasm, epicardial or microvascular spasm, then I am entitled to increase the dosages of calcium antagonists beyond what is the average dosage. But if I don't have this evidence, I mean, it's difficult to push my luck if I don't know whether I am on the right track. While if I know the mechanism of ischemia in my patient, also if I have to push the treatment because current doses are not sufficient, then I am entitled to do it. This is why I said, well, as doctors, we function better if we know the precise mechanism of the disease. If I know the mechanism, I am more confident in using the most appropriate antidotes.
Well, thank you very much. Very insightful indeed. See many cath lab reports saying normal angiogram, non-cardiac, refer to GI or psychiatry. I think cardiologists need to revisit their way of thinking. Many of us need to really be insightful and cognizant of these caveats that you mentioned. So going back, Professor Kriya, about your milestones, what do you consider to be milestones in your research journey, since this is a forum about cultivating research and giving kind of pieces of wisdom to people? You already took us through your insights about functional alterations of coronary function and so on, but there have been success recipes, if I might say, behind all these achievements in research. You mentioned teamwork, working with other mentors in London and other labs. What would you consider things that played a major role in your career?
Well, the major role definitely relates to mentors. I think that in research, having the right mentor, an important mentor, is extremely helpful. And in my life, I've been very lucky because my mentor has been Professor Attilio Masseri, who passed away a few months ago. And with Jim Browngold and Valenter Fuster, we have written a very intense tribute to him. We co-published in the European Heart Journal and JACC. And what I've learned from Professor Masseri is just what I told you: not to accept the dogmas. If there's something in your clinical, and this is the message also for our younger colleagues, if there's something in your clinical practice which you don't understand, which is not explained by textbooks, well, the reaction shouldn't be, okay, if the textbook says that this is the case, I must respect what is written in textbooks. No, the reaction should be, well, if what I see is not explained by textbooks, probably they are wrong. I mean, we must have the courage to tell ourselves if something is not explained by current wisdom, well, is wrong. I give you another example, which is again related to the dogma stenosis ischemia, but this is more recent, and this is the chapter of MINOCA. MINOCA stands for myocardial infarction with non-obstructive coronary artery. Well, if the dogma ischemia can only be caused by stenosis is true for angina, well, this is what was even stronger for myocardial infarction. The idea of having myocardial infarction without stenosis a few years ago was a crazy idea. But what made the change? The change was made by troponin. Because troponin is so sensitive and so specific. And this is why, again, it was not just me, it was a group of colleagues, was not just my observation, although I gave my contribution. So the problem came when patients with severe chest pain, suggestive of infarction, were admitted to CCU or to the emergency department before troponin. Well, these patients, again, were patients good for the psychiatrist because this pattern is different from angina. Angina is recurrent, but these were patients with a single isolated episode of severe chest pain, suggestive of ischemia, but normal ECG, and probably you remember CK&B now is not used any longer and shouldn't be used to this end, but at that time was the only available thing, CK&B, which was negative. And then troponin, high sensitivity troponin reached us. And then I started seeing that these patients at normal levels of CK&B, but troponin raised. So I asked myself, well, are we sure that these are not ischemic patients? And this brought to the important chapter of MINOCA, myocardial infarction with non-obstructive coronary arteries. Well, these patients have been under our eyes all the time, but was only with troponin that we understood that there was something wrong in their heart. So at that time, the challenge was to tell ourselves, okay, until yesterday, these patients, because of normal CK&B, were considered not to be ischemic. But now, with troponin, this is against what we read in textbooks. But if troponin is positive, really, we need to know what happens here. And then MINOCA, for the first time, entered the guidelines in 2017. MINOCA has been reported in a guideline for the first time, and had the honor to be part of the task force writing these guidelines, has been in guidelines for the first time in 2017 in the guidelines of the European Society of Cardiology on STEMI. And then once we've identified that that infarction can also occur in the absence of obstructive atherosclerosis, well, now the recent epidemiological data show that 10% of myocardial infarctions are without obstructive atherosclerosis. And we admit a massive number of myocardial infarctions. 10% is 1 out of 10, is a huge number. And these patients were missed before because there was no troponin. Well, another example is Takotsubo syndrome. I contributed to the study of mechanism of Takotsubo syndrome, but Takotsubo syndrome was discovered by our Japanese colleagues. And Takotsubo probably has been with us forever, but was identified only 15, 20 years ago with a very simple approach. These were patients with, as you know, ischemia, in this case, typically troponin raised, which is not massive, but is present. But these patients were found to have normal arteries or non-obstructive atherosclerosis and were dismissed. Then this colleague in Japan had the fantastic idea of performing the ventriculography, injected contrast medium into the myocardium, and he found the typical Takotsubo shape. Again, was serendipity, was fighting against the wisdom. If infarction comes without obstruction, cannot be myocardial infarction. So this is what I've learned by my mentor, Professor Masseri, to challenge what is against current wisdom, to challenge what is not explained by current wisdom. And if we carry on with our discussion, I can show you other examples of how current wisdom needs to be changed.
Thank you. Thank you. Very helpful indeed. These kind of examples just highlight how we can change textbooks of medicine if we become more observant and not accept the status quo and the dogmas. Switching gears to something that is close to your heart and just something that you already took charge of, the European Heart Journal as an editor-in-chief, already very successful journal, and you're making it even more successful. So tell us about the what has been really happening in the last couple of years under your leadership, and what is the vision for such a top-notch cardiac journal?
Well, thank you for this question, Khalid, because it's, of course, a very important question. And I do my best to be clear. My vision of a journal is that the goal is not to have a high impact factor. Of course, we want to have a high impact factor. We want to publish top science. We want to publish game-changing studies. We want to advance our knowledge. This is fundamental. It's a fundamental goal for a journal. But my vision of the journal is something wider. I think that the ultimate goal is to reduce the burden of cardiovascular disease, but with a global approach. The influence of the journal should be global, in my personal, humble opinion. The influence of the journal should be global and should create a link between authors, readers, and cardiologists and reviewers. I mean, we all belong to the same community around the globe. I think that this is something which was present in the European Heart Journal before my experience as editor, but I've made some efforts in order to improve the globality of the journal and also the involvement of the colleagues with a series of initiatives. One initiative has been the creation of this panel of global co-editors like you. You are our co-editor for Middle East, and I'm really grateful for your contribution, great contribution to the journal. We have co-editors from Asia, we have co-editors from Africa. Actually, on Thursday, we had a nice dialogue with Karen Sliwa, who is the cardiologist of Cape Town. We have co-editors from Australia, of course, from Europe and from the States. We don't have a co-editor from Antarctica yet, but I'm planning to have it. And I think that this global flavor, where these ambassadors of the journal create a link with the journal and their geographical area, is a contribution which goes in the direction I was saying, the globality, creation of a community which where it is important to share top level papers, but in addition also the creation of the link again among editors, authors, and cardiologists around the world.
Great vision indeed. How about the some examples of new sections in the journal, things that have been really different or new compared to the previous journals?
Well, one section we have renewed is Cardiopaths. Again, with the focus, I always encourage our co-editors, you and the others, to provide good pieces for Cardiopaths. Cardiopaths is a window open on the world, on the 5 continents, and where what the purpose of Cardiopaths is to know what happens in the 5 continents, which is of course of interest for the cardiological community. If you have important initiatives, the opening of important hospitals or teaching facilities, in colleagues who are performing innovative things. I mean, what is of interest for the cardiological community in your geographical area or in other areas, again, from Asia to Australia? Well, it's something which can be of interest for the journal. So I shaped Cardiopaths in order to have this part of the journal open to really the important things in the field of cardiovascular medicine, which happens in the 5 continents. Then another initiative, very straightforward, but I'm finding this initiative very rewarding, at the dialogues every month, and all our colleagues who are listening to us are cordially invited. It is free. And you can find you can find the link in the website of the European Heart Journal. We have these dialogues on the last Thursday of each month at 5 Central European Time. And these are dialogues with top cardiologists from the world. Well, the term dialogue is a Greek word, which was introduced for the first time by Socrates. And Socrates strongly believed that dialogues are a way to reach the truth. I mean, you can believe it or not, but these dialogues are really Socratic conversation, like the conversation we are having today, in order to improve our knowledge, in order to understand what we can do in order to improve our knowledge. And the conversation with colleagues with a large experience in the field of cardiovascular medicine can be very inspiring also for the young generations. Then another initiative I have started is the weekly journal scan, because we should have always an open mind. And the weekly journal scan works in this way. The editors of the weekly journal scan, they scan what is published in important journals, in general medicine journal, New England, Lancet, BMJ, important journal, but outside really the cardiological journal, so to speak. And they identify every week what is the best, the most exciting, interesting paper published in this important general medicine journal. And they write a summary of this paper, and also with an editorial comment, which usually is quite interesting. So this is another way really to open our mind, to focus not only on what is strictly in our field of cardiovascular medicine, but also in surrounding areas which can be of interest for the cardiologist. So a number of initiatives with the goal again to make the journal as global as possible, as open as possible, where the goal is not just to have a high impact factor, but more importantly, the goal is the reduction of the burden of cardiovascular disease. Another innovation I brought to the journal is the expansion of the editorial board. In addition to the co-editors, who are the ambassadors of the journal in different geographical areas, I have a large editorial board of deputy and associate editors, who handle manuscripts for acceptance. All submitted manuscripts are handled by 20 mini teams. Each mini team is composed by one deputy editor and two associate editors, so a prominent cardiologist, again, from the world, not just from Europe. And we have identified 20 fields of cardiovascular medicine, which means that if a manuscript is submitted on hypertension, this goes to the mini team made of experts in hypertension. If it is a paper on ischemic disease, we have another mini team expert in ischemic disease. And this allows really a very careful assessment of the papers we receive in order to take the most appropriate decision. Our attitude is to improve the papers. I mean, of course, acceptance rate is very low; it's in the order of 3-4%. But for those papers which are eventually accepted, as editors, we do our best in order to improve their presentation, in order to increase their impact. And this is a very complex organization. It's also time-consuming, but it is also very, very rewarding.
Well, congratulations, Professor Crea, for such a great vision. Probably we should rename the European Heart Journal to be the World Heart Journal or something. So this is amazing, and usually the impact factor, I'm sure it will follow through as well.
This wouldn't be allowed by the European Society of Cardiology, but the spirit is precisely what you're saying.
Exactly. A question here from Dr. Wael Garawi, who's one of our consultants in our hospital. What one thing you find done poorly in the peer review process in journals in general, and how do you see it fixed? The peer review process has been always criticized, and some people even claim that it is it's not even needed or need to change to another system. What's your take on this?
No, well, I think that the system is not perfect, but it is difficult to find a system which works better. What is important is really the quality of the reviewers. But we are lucky because the average quality of the reviewers we have for the journal is really excellent. In one of the next issues, we will have 3 pieces in Cardiopaths, really praising our reviewers because they are doing an excellent job. We have also, I mean, this will be announced in this issue, which will come out in a couple of weeks, 2 or 3 weeks. We have created a mentorship academy for really enrolling reviewers. Each editor will identify one. It will work as a mentor and will identify one or more mentees to involve as reviewers. So this is a way to incentivize the participation and also the formation, the education of young reviewers. So we want to help in this direction, promoting the education of young reviewers. This is one initiative. Every year, we also give awards to our top reviewers and this will be the case during the editorial board meeting we will have in Barcelona. I think that it is difficult to, at least I cannot think of a better system. It's not perfect, but if we help our reviewers, if we implement this mentorship academy to really prepare new reviewers with mentors and mentees, and also if we work as editors, because it happens that for some papers, at least some reviewers really do not give the best they can give. If this is the case, then it is our duty as editors to improve the work of our reviewers. And this is what I do, and the editorial board does every week. When the comments of the reviewers can be improved, then we do it as editors. So at the end of the story, involving good reviewers which are out there and we can be identified. So selecting good reviewers and working as editors on the top of what they do in order to improve manuscript presentation, I think that at the end of the day, we can really make a good job. If you have suggestions, I'm open to really implement them. But at the moment, I don't see a better system. If you have suggestions, open and happy to hear to you.
Yeah, I definitely agree. I guess one of the frustrations, or among the top frustrations, that researchers sometimes send jokes that their manuscript was like looks like a tiger before the review, and then looked like an alien after the review process. And people think, well, I'm kind of gonna get along with the review process, so I can just get it published. And then the manuscript loses its identity or the main message, whether it's good or the bad. As you mentioned, it is the system that we have so far. It's all about the choice of good people with good expertise in the area. It has its own good and bad, but this is the nature of the process. In terms of one of the other major tasks to objective of this forum as well, to pick your insights about what it takes to publish in high impact journals. You mentioned many of them, but some people get taken away and excited, and they feel that their research is the best in the world, and they go immediately to top journals. And probably they need to be more humble and probably target more local or regional journals. And this is what puts researchers down, that they kind of dream a lot or bigger than the actual manuscript, and they waste a lot of time and effort by trying to approach top journals. So I guess the question is how do you know as a researcher that this is worthy of submission to the European Heart Journal, for example, or what do you look as an editor for this?
Well, Khalid, I think again that the system, the way it is organized, works, is not infallible. But then we have the test of time. The test of time is the most important, in addition and beyond what journals can do. If something is good, sooner or later comes up, even if it is rejected. So the test of time is the ultimate test. And I also tell you that, and please don't be surprised, that I have several papers. Even now, my papers I send to the European Journal, which are rejected. When I send the paper to the journal, of course, a guest editor is not assessed by me or by my editors. We have a guest editor, and regularly it happens that my papers are rejected. But this is part of life, and perhaps this is the beauty of this type of life, which is very challenging. And the way, even when you feel, well, this is important, I want to publish in the European Journal, I feel that it is better, it's fine to submit, and then the paper is rejected. And this should tell you something, because what do you say?
I feel better.
So it's part of the game. Well, suggestions. What is important to publish in the European Journal? Well, you know, the first thing is to publish something which is novel, which is clinically relevant. I mean, we are not a basic science journal, we are a clinical journal. So we want to publish what is clinically relevant. And you know, this is something, I go back to my mentor, to Attilio Masseri. This is something he told me long ago when I started my career. And he told me, listen, Filippo, when a fertile mind, and he told me, you have a very fertile mind. But if you have a fertile mind, you are flooded by ideas, by working hypotheses, by projects you'd like to carry out. A fertile mind is flooded by questions, because if the attitude is to challenge what you read, if the attitude is to challenge the dogma, then many questions come to your mind for things which are not explained by current dogmas. But it told me, the question, the problem, the difficulty is to identify the important questions. Not all questions which come to a fertile mind are equally important. So the challenge among this huge amount of questions which flood the fertile mind is the ability to identify what is, in our case, clinically relevant. This is the most difficult part of the study, because then the methodology to test your hypothesis can be found, can be more complex, more or less expensive, but the methodology, the sound methodology can be found. So my suggestion to my younger colleagues or colleagues in general is, please try to identify the important questions among the many which come to your mind. And coming to young colleagues, because research is also expensive. You need grants and you need money. If we have an inquisitive mind, but we are young and you don't have enough money, and perhaps you don't find a good mentor who believes you, then anyway, you must exercise your brilliant mind with something similar. Can be case report, can be a simple case report. In the European Journal, we have flashlights. So if you have nice cases you want to share with the others, this is not expensive. Just find something which is attractive to share with your colleagues. Well, this is something young colleagues can do. Another thing which can be done without really investing huge resources are meta-analysis. I encourage my young colleagues in my institution to consider, to perform meta-analysis, because frequently they are useful. But again, what is important? Because not all meta-analysis are equally important. I keep receiving meta-analysis of, let's say, 5 trials. The question is, does treatment A work better than treatment B? Then meta-analysis. Well, if the 5 trials all show that treatment A is better than treatment B, you don't need a meta-analysis to prove it. But I keep receiving this sort of meta-analysis also from excellent researchers, which prove what has already been proved. So again, please ask yourselves the important questions.
So having the research and the clinical mind together, very important. Don't forget your clinical observation, and don't just focus on research.
Absolutely.
Some people just want to do research, that's it.
Yes, I mean, good clinical research comes from clinical questions. Yes. The best ideas for research came to me during my ward round, asking patients questions, and the patients gave me questions which were not explained by textbooks. That was the most interesting source of research. Clinical research typically starts from the ward, goes to the cath, goes to the basic lab, and then goes back to the ward. This is clinical research. But in this case, you need a bit more money, a bit more years of experience, and it is more complex. But what then I found very useful in my career as a researcher has been the creation of a basic lab adjacent to the ward, which creates a nice link. So the question comes from the ward, then I test it in the cath lab, and then the results of this type of testing can sometimes is useful and goes back to the patients. This is something which in my experience, I found very interesting. But I mean, this is not for young investigators. You need a bit more experience and time to develop a system where basic research and clinical research go together. And then when, with the passage of years, when the hair become white or they are lost, like in my case, then you appreciate that an important thing is teamwork, like the journal. This is not the era of soloist any longer. The good things which come from the research are fruits of teamwork. Teamwork in our research time is extremely important. And in this teamwork, the contribution of young and less young cardiologists is equally important.
Very nice. Well, I have to say, this 1 hour was very exciting, and I learned a lot. I wish it would have been another 2 hours, but we couldn't. So, any last remarks? Any suggestions for such a forum from your side to even build on it? Any last remarks?
Well, one last remark is about, I told you, well, I find very interesting to always to start from patients, clinical questions, to give a clinical answer. I encourage my younger colleagues also to always read a lot and study literature. And I bring a last example of something I'm investigating now. More than 20 years ago, about 25 years ago, a great pathologist, Michael Davis, he published a very interesting study. It was a series of patients died sudden coronary death, and he found that in 40% of patients there was plaque healing. I mean, he found plaques with recent healing. It was possible histologically to identify plaque healing, and that was found in 40% of patients. Then, some years ago, going through the literature for other reasons, I found this paper, which was really interesting because, I mean, all our emphasis has been in the last years on plaque disruption, but plaque healing was totally forgotten. So I went back with young colleagues, Rocco Vergallo, and now we have this wonderful microscope, which is OCT, which can, the resolution is what we had with histology. And with OCT, it's possible to really identify plaque healing also in patients. You don't need the postmortem. With the patient still alive, by OCT, you can identify plaque healing. And then we published this study in JAMA Cardiology showing that patients with stable angina compared to patients with recurrent episodes of infarction, patients with stable angina have a much higher prevalence of plaque healing. So plaque disruption occurs also in patients who are stable without infarction because they have the ability to heal. And then we published a review article 2 years ago in the New England Journal of Medicine. The title is Atherosclerotic Plaque Healing, proposing how the study of plaque healing can really identify a new therapeutic target. So these and other suggestions for my younger colleagues, not only patients, but go to the literature. And if you find something interesting, which has been totally forgotten, please try to revive it.
Well, thank you very much, Professor Kriya. This has been really exciting and very insightful from your side, and would like to thank you again for your generosity and being with us in this platform. Can't thank you enough. It has been a great pleasure and honor to have you with me.
Thank you also for your contribution. It's quite really fantastic.